you can pick up any study you want to look at, and what you'll find when you look at the rural population is they tend to be sicker than the general population, and they tend to be a higher percentage of them are uninsured, or on Medicaid or on Medicare. But you also have a lot higher percentage of smokers, a higher percentage of diabetes, of COPD, of frankly morbid obesity, right? And so those chronic conditions that lead to poorer health are more prominent in rural America. And so that's a reason why we have, as Scott said, 13 rural health clinics spread around a pretty big area, all tied to our critical access hospital. Because another issue for those patients is simply, transportation and getting into. So it works better if you're going to be a medical home and provide primary care and try to keep patients healthier so that they're not having to access a hospital. You catch them before they get acutely ill and hit the hospital ER. You've got to be out where they are.
Well, we're here with Paul. He's the CEO of Ozarks Community Hospital, and Scott is the hospital administrator over at Ozarks Community Hospital. Paul and Scott, thank you so much for your time today and joining us on the podcast.
Sure.
We'd like to jump right in. For those that are less familiar with the rural hospital space as a whole, Ozarks Community Hospital is primarily Missouri, Arkansas region, correct?
Correct.
Okay. So why was focusing on rural and lower income communities so important to both of you?
Well, it started with me, and I, as an attorney, I was involved in a project where we took a underperforming hospital, and the group that I was representing, group of physicians, it was physician-owned hospital, mostly were motivated to kind of flip it, increase the productivity of it. And so I was involved in a merger of that hospital with HCA, who owned another hospital in the area. And so we merged, and eventually, as I expected they would, they closed our hospital, which was the smaller of the two in the market. And long story, which I won't go into, but I was able to get that hospital facility back out of the merger. And by which time it had been sitting empty for 2.5 years. And I decided I really wanted to be involved in a project where I would reopen the hospital and focus on providing access to care for patients who had a difficult time accessing care. At that point in time, it was in Springfield, Missouri, that hospital, and there was a huge problem with providing access to care for Missouri Medicaid patients. And so the idea was, let's get it open, and let's make certain that we're providing both primary care and hospital care for that patient population.
Interesting. Okay. So when you say underserved, you said you referenced at least the Medicaid side of things, but how would you define this underserved population that you were trying to
Good question,
serve?
Because my definition of underserved and those patients who have a difficult time accessing care has actually evolved over time. Sure. Because in the beginning, and particularly there, the access to care problem was, sure, the uninsured population has a difficult time accessing care because unless they're hitting a hospital emergency room, they find a difficult time, getting into a physician. And so, unless they're acutely ill, they don't access care. Okay. And that was really true in the Springfield area of also the Missouri Medicaid population. Why? Because Missouri Medicaid paid so poorly that typically health systems and providers, physicians were reluctant to take a high percentage of Medicaid into their hospital or into their practice because it paid so poorly. Sure. So in the beginning in those days, and we're going back to the early 2000s, it was really the patients, and some of those patients, it would include, a lot of Medicare patients. And so those are the patients that perceived as being, poor paying patients, uninsured, Medicaid, Medicare patients, preference being given time and access to private insurance patients because it pays better. Sure. And so we focused on providing care to that underserved population based on payer source over time. And as some healthcare reform has, taken effect, Medicaid expansion has taken effect, really what you begin to see is not so much an access to healthcare problem based on payer source, but an access to healthcare based on the patients themselves and the fact that the patient had some sort of difficulty or some kind of characteristic that made it difficult for a primary care physician or a hospital, for that matter, to deal with them. And what do I mean by that? Well, for example, a large segment of the population that, and again, maybe, uninsured Medicaid, Medicare patients, especially in the rural areas, but they have medical and behavioral comorbidities. And so they're a difficult patient because they're difficult to manage medically and behaviorally. Because, if you take a patient like that, if you're a physician, a medical doctor has got to deal with the medical issues, but they've also got this whole boatload of behavioral problems that they don't feel equipped to deal with, and they don't have, in their practice, they typically don't have a psychologist or a psychiatrist sitting right in the office next to them, right? So over time, that became our focus, is to identify those patients that were having a difficult time accessing care or getting the kind of care they needed, at least, because the patient themselves presented difficulties.
Interesting. Okay. So that definition has changed over time, it sounds like.
Yeah.
Interesting. Okay. And so let's kind of step back big picture, hear a little bit about your role as a hospital administrator. So we've defined more clearly, right, the underserved definition here now as it stands, and as you guys are helping this specific population. What kind of role do you play in serving this underserved population in this area as a hospital administrator?
So it's a bit different, as he was talking about how we got into serving the underserved.
Okay.
That hospital wasn't necessarily incentivized from a reimbursement standpoint for doing so, because they weren't a critical access hospital. So they were just seeing those patients because the other hospitals wouldn't,
Sure.
for the most part, because it doesn't pay well. That hospital focused on those patients because that's who needed the care, and that's who was left, basically.
Sure.
We are a critical access hospital in Gravette, Arkansas. He opened that in 2008. It was also closed again. So reopening 2 hospitals. This one was a critical access. So serving the underserved is literally the job description for any hospital designated as a critical access, right? So, for that, it's our direct community for our hospital, hopefully serving everyone in our population area, but also it allows our rural health clinics from Gravette, Arkansas up to Springfield, where the old hospital was. There's 13 of them. It's attached to the critical access designation. So while it's not feasible for a ton of our patients further north, because that's almost 2 hours to drive to our hospital, but at least for the 6 or 7 clinics that are directly in our kind of capture zone, we would like to feed from our primary care physicians in those and NPs in those clinics, and kind of we have specialties at the hospital like ortho and general surgeon and what else we got? Pediatrics.
ENT.
Yep. So when they need specialized care, we hope to be able to provide that for those folks in those outlying clinics in our direct capture zone.
Gotcha. Okay. So a lot of dynamics in play here. So again, many patients living below, it sounds like, below the poverty level. You said there's both the medical side and the behavioral side. So it creates a lot of dynamics.
That dynamic, so when you drill down to the rural, that you can pick up any study you want to look at, and what you'll find when you look at the rural population is they tend to be sicker than the general population, and they tend to be a higher percentage of them are uninsured or on Medicaid or on Medicare, but you also have a lot higher percentage of smokers, a higher percentage of diabetes, of COPD, of frankly morbid obesity, right? And so those chronic conditions that lead to poorer health are more prominent in rural America. And so that's a reason why we have, as Scott said, 13 rural health clinics spread around a pretty big area, all tied to our critical access hospital, because another issue for those patients is simply, transportation and getting into. So it works better if you're going to be a medical home and provide primary care and try to keep patients healthier so that they're not having to access a hospital. They don't, you catch them before they get acutely ill and hit the hospital ER. You've got to be out where they are. And so that's one of the things we try to do is be diffuse in that regard, so that, and that's the important concept of there is that all of our rural health clinics are accredited medical homes, and we spend a lot of time and energy, and money, frankly, staffing those rural health clinics with community health workers and people that go out into the community, so that the touches are not just the touch that when the patient comes in to see the physician or the mid-level, but there are nurses and other community health workers that are contacting the patient or going out to see the patient to make certain that they're dealing with some of those, the catchphrase now is social determinants of health, SDOH. And too often in our industry, once we create an acronym, we think we've solved the problem, right? And so that's kind of where we are now is they rattle off SDOH, and I think half the people that say it don't even really think about what it means anymore. But what it means is you've got a patient population that's dealing with issues that are more than they can individually control, that are detrimental to their health. And you cannot successfully treat a patient like that if all you're doing is treating them when they walk into your clinic and you try to fix whatever's broken, from that standpoint. So you have to reach out and try to, kind of help them deal with whatever's happening in their environment that is leading them to be maybe less likely to make an appointment or more likely to get a bit depressed and kind of give up because they've always been unhealthy and they can't ever seem to get on top of it. Why? Because, in our situation, we do things like, honestly, before we discharge a patient from our hospital and grab it, we go home and do a home visit, and if we find out that, their environment is not healthy, we keep them in the hospital until we can. We've gone out and had to reconstruct some homes, frankly, because you can't get them back into their house if the porch is unsafe, or if you got a patient that's dealing with an intractable wound issue, and you spend 30 days, growing new skin, and finally you feel really good about that, and so. The Bible says you got to send them home and you got to discharge them. But, if you send them home, they're going to be in an environment where it's not a very healthy environment. And that if they're there for a week, the wound is going to become acute again and they're going to end up back in the hospital. So what do? We send beds home with them. You send home health workers home to try to make certain that the wound care is appropriate when they get home. That's the sort of thing that you have to engage in doing if you're going to reach out to the rural population that you can't expect that population to have the kind of resources at home to make certain that they can participate in their good health. They need a bit more help.
Yeah. Yeah, a lot of dynamics, like you said. That's amazing. So it makes me think of a couple of things, and curious on both your thoughts here. So first is just getting them access to the facility. Like you said, you have your clinics that help with that, right? Decrease the just total travel time from home to access of care anywhere. So care is rendered. Have you looked into and explored options for remote care, remote patient monitoring, remote therapeutic monitoring, or any type of mobile care, right? I know that's gaining some traction, attention in certain areas. Have you looked into having like a mobile unit or van, so to speak, to go to some of these regions where you have
I've always
people?
Wanted a mobile rad lab.
That'd be amazing.
Yeah, it would be amazing. But instead, we just replaced our CT and X-ray room because stuff had been falling behind for a while. So we're almost live with our CT, which is going to really improve things in radiology because it would go down, every week. We'd get an email from our radiology manager saying, hey, we're down. So then that affects a whole lot of stuff because we have an ER that we have to divert and our docs, ER physicians don't love that. So yeah, I mean, that type of thing would always be great, but it just, when you are in a rural healthcare system, cash on hand is not a big thing. So you have to take care of the things like if you need a new CT or you need a new rad room, instead of retrofitting what do you call those, transistor vans, or the things they turn into the things they take to the beach now, and put some x-rays in the back of that and drive that around. That would be awesome. But also, reimbursement is not great for trying to accomplish those things. Right. So you have to have the money to be able to do it, hoping you'll get reimbursed for the services on the back end, with no guarantee that you will. And it's just it's not there yet, I don't think.
You're doing more with less all the time, and then you're always subject to the rules that the payers are creating.
Yeah, we do our fair share of telehealth, and of course during COVID everybody did, and so there's some holdover from COVID but honestly, when you have a patient population that is in rural America, doing telehealth presupposes that they've got internet access, which is not always the case, and even when they have it, it's not very reliable.
Yeah, or do they know how to use it appropriately?
And they don't know how to use it. And honestly, you then try to upgrade. You work with grants and other services, try to upgrade technology, and honestly, a lot of these things tend to start big and then falter along the way because it's not really sustainable. And it can be a pretty mobile population too, and so kind of hard to keep tabs on folks, which is why, for the most part, we've since COVID have kind of gravitated back towards really focusing on getting them into the clinics, and so I see a future where with a more sustained effort, there's more and greater technology in the rural areas, so that you can expand out and try to provide more of that care in their homes. But our hybrid approach right now is to at least make certain that we're putting clinics where they have a 10 or 15 minute drive and not a 2-hour drive.
Yeah, it's smart.
Yeah.
Order of operations, right?
Yeah.
And again, cost is one of those things you always have to keep in mind. So talk to me a couple other thoughts I had. So compliance. I'm assuming, again, with the population you just described, primarily that you're seeing in these facilities and in your hospital, compliance is important for anyone to improve medically in a condition that they present for. Mm-hmm. How do you work with the challenge of patients being compliant with what you ask them to do once they leave the facilities they're seeing you in for care?
Yeah, I think the key for us is what I alluded to earlier, and that is you don't lose contact with them. And so the best way to do it is the follow up it's the follow up telephone calls. And yeah, I mean, if they have the technology, you're texting them, or emailing them, so we do that. But a telephone call where it says, well, look, we've noticed that the doctor prescribed such and such medication for you, and you haven't filled it. Which means that we've also had to work a great deal on data sharing, because for us to be able to say that, we've got to have data from the pharmacy, sure, telling us whether or not they have filled that prescription. But beyond that, just whether it's calling about are you taking your medicines, or how are you feeling today? Actually, a big part of compliance is simply reminding them to come in for the visit, because you have a fairly high no-show percentage as well, and we try to treat non-compliant behavior. So you can call it a social determinant of health, whereas that non-compliant behavior may be a product of their environment, their social environment where they are. But it also, because I don't know where you divide it up, is also a product of their behavioral health. And so we often treat a non-compliant patient as a patient who is suffering from a behavioral health problem. And so that's why we were trying to employ so many LCSWs and psychologists and psychiatrists to address non-compliant behavior in patients, because that behavior becomes a medical problem, right? If they're not coming into their visits, if they're not taking the medications as prescribed, if they're not following up with the diet and those sorts of things. And how do you do that? How do you get them to address that behavior modification? Is it because they're depressed? Well, maybe they're depressed for social reasons, and there's a real good reason for their depression, right?
Sure.
So it's a whole, spectrum of things that you're trying to address with that population.
Makes sense. Well, they're very interconnected, like you said. That makes sense. And so going to your point on hiring more, right, social workers, et cetera. Yeah. I'm assuming, again, curious on your thoughts. How challenging is it to find qualified healthcare workers of any specialty, including behavioral health, to come work in these more rural areas and offer quality care?
It's not difficult. I mean, it has been for the last couple of years. I think that's across the board, though.
Sure. Post-COVID, another story, right?
But we have the folks that would be able to provide the outward service of healthcare if they weren't tied down to their desk. So we have MAs and we have LPNs and the LCSWs. Those folks who got into healthcare to help people. That's why they're still with us for as long as they have been, or in and out as it is sometimes. They'll be with us and then they'll go test the waters at a bigger health system, and we have a good return rate. But and this is where like a thing like Scribe comes in, where it's eliminating some of that work tax for the folks that don't want to be on a computer all day. That's not why they came to the job interview. That's not why they went to school, right? They want to be helping people. And when they're locked into a desk job for just to make sure an encounter gets processed the right way, through the entirety of the life cycle of a patient, adventure at a healthcare system, that is not what they want to be doing. And what they could be doing is being out in the communities and trying to accomplish all the things that he was talking about earlier.
Yeah, if you want you want the business model for that, I can give it to you, because the point to a technology like Scribe is it makes your providers and staff in the clinic more efficient, which means they're going to be able to see more people in the same amount of time. Well, that's going to generate more revenue. And in a rural health clinic, or any other clinic, the more revenue you generate, the more money you have, and the more money you have, the more staff you can hire. And for us, and for anybody else, but in a rural health clinic, you have a certain amount of money typically per visit to work with, right? And if you can leverage that revenue stream to expand your workforce so that you can hire more community health workers, where they can do the stuff outside of the visit. Well, how do you pay for that? Well, the only way to pay for that is to make the piece that is still in the way our health system works. It's really driven by the visit, right? So the turnstile count is what drives revenue for the most part still, because you're not being paid for the community health workers, right. Okay? So you got to pay for them. So how do you pay for them? You get more efficient in doing the stuff that does pay, which is the turnstile, the visits. If you increase your visits and you're providing great care and being really efficient in doing so, then you can expand the service that you're providing using that additional revenue, hire more community health workers and get them out in the community. So you're trying to tackle some of those social determinants of health, and you're also able to hire more folks like the therapists, the mental health therapists, the LCSWs, where you can have both a mid-level or a physician providing medical care and a therapist providing some behavioral health care in the same visit, in the same facility. You can't possibly do those things if your clinic is not as efficient as possible, right? And so that's the ball game. You have to figure out ways of taking the existing revenue stream in this healthcare industry that we're given and make it very efficient and maximize it so that you can actually provide the level of care that you want to provide.
It's well said.
Yeah.
It's well said. And again, one tool being an ambient documentation tool to be able to do what you just said, right? Decrease the amount of time it takes to render care, right. Create more opportunity for seeing potentially increased patient load, and then increasing revenue to the next floor. So say that happens, right? You guys are currently using an ambient documentation tool called Scribe. Say that the process you just described occurs. Your revenue increases as a result based on what we just talked through. You mentioned hiring more workers for sure. That's number one, especially in behavioral health. What about from the technology standpoint? Anything you guys have on the roadmap in the future of like, hey, as we continue to improve efficiency, increase our revenue, here's some ideas of things that down the line we'd like to consider looking into to continue to make this overall operation more efficient?
Well, honestly, you know what, where we are and where most rural health systems are is we are competing increasingly against commercial insurance companies that have technology that we don't. Yeah. In terms of denying claims. I mean, it's what it comes down to. So we're dealing. You have to understand the history for a rural health system is, you know, we all grew up, and I've been doing this for 40 years almost. So we all grew up dealing with Medicare and Medicaid. And the beauty of dealing with Medicare and Medicaid is they didn't pay you that much, but if you sent them a clean claim, they paid you, and they paid you pretty promptly. And so when you grew up over decades, you know, working in a system where you could rely on a certain revenue stream because it was all Medicare and Medicaid, you learned to live with not the higher paying commercial insurance stuff, but you didn't have to deal with the commercial insurance payer behaviors that other health systems, the bigger health systems, have long history of knowing how to deal with that. And they also have the money to buy the technology to help them to deal with it. Well, what we're dealing with now in rural healthcare is, because of the increased percentage of Medicare that is now Medicare Advantage, which means commercial insurance, of the Medicaids, which have been privatized, which means Medicaid Advantages or whatever you want to call them. And now you're dealing with payers that are paying you the same less amount as the governmental payers were paying you, but now they're using their technology and resources to deny claims. We looked at it, you know, over a 2-year period, and we found that the Medicare Advantages were collectively paying us 20% less than what Medicare was paying us, even though they're contractually obligated to pay us what Medicare pays us. Well, how do you deal with that? And we don't have the technology to deal with it, or we haven't been able to afford it. And so we deal with it with our same billers and our same revenue cycle people that grew up just simply dealing with Medicare and Medicaid. Well, they're not really equipped to do it. And so one of the things that increased revenue would help us do is to reach out and access that kind of technology, which would allow us to just kind of defend ourselves against commercial insurance payers, right?
Fight fire with fire.
Yeah, and that's where our health system, and frankly a majority of other rural health systems are right now. Over 50% of rural hospitals have a negative operating margin right now. And there are, every time you look at the report, there are over 500, somewhere between 500 and 1,000 rural and critical access hospitals in this country that are in danger. You know, what does that mean? You know, they may close sometime within the next year or two. And we have to do something collectively to flip that margin back in our favor. And the biggest challenge to us all is dealing with the increased preponderance of the commercial insured payers and their behaviors in denying claims.
Yeah, which we all are a victim to, right? We have to play within the subset of rules that have been provided for us.
Yeah.
It's just the name of the game and the broken system we all exist in. It's why I'm not practicing anymore. I got tired of the game, right?
Yeah.
So I wanted to go work somewhere that I could start to kind of work on the problem, not be in the problem as much, to try to help groups like yourselves or others across the country.
And then the problem for us in terms of like acquiring that technology is, one other truth for rural health systems is we don't have access to a lot of capital.
Right.
And up until this point, up until recently, the only options for us were pretty capital intensive. Right. I mean, if you want the technology that can fight against the commercial payers, you have to have the money to pay for that technology. And so, yeah, there are now, you know, more revenue cycle management, you know, vendors out there that are looking at, well, we can do this without a lot of upfront capital. We'll simply do it on a revenue kind of, you know, percentage basis. And so that is an area where myself and a lot of other, you know, rural health system, you know, management folks are looking right now.
Sure. Makes a lot of sense. I think ultimately, I mean, tying this all together, right? Coming full circle here is, can you fight back, of course, but more so ultimately why, right? The why to why we're in this, why you're in rural healthcare, why I went into medicine, like the entire essence of what we're trying to accomplish is just providing quality care to the end user, which is patients, especially in these underserved populations, right? They're the people that need it the most. That's why I get, again, this is my personal bias here a little bit, but I get so worked up about what you just said. It's so concerning that there's so many critical care access and rural hospitals at risk. Because what happens to those patient demographics if they don't stay in business? That's a huge problem. Huge
Yeah, because I
problem.
can tell you the attitude of most people that live in rural America is, if the choice is, because we deal with this all the time, where we'll have a patient that we say to them, this is some kind of specialized care you need that we don't provide. You need to go to the tertiary care system like an hour away or whatever in a bigger city. And they'll simply say, nah, if that's the case, I'll just stay home and die. And so, and honestly, so the truth is, if there's two real scary issues about the closure of rural hospitals, and one is, that if you're going to have another pandemic soon, which we feel like it's just going to happen at some point. If you have a bunch of rural hospitals that have closed during COVID, a lot of those rural hospitals had to staff up and bed up in order to handle that influx of patients, right? We doubled our census from 25 to 50 during COVID, right? And so there was a lot of beds that were occupied during COVID. There was a surplus of capacity existed because rural hospitals still existed. And we were able to ramp up and take care of some of the overflow from the urban hospitals. So that's one thing. There's some kind of a buried surplus capacity out there in maintaining and keeping these hospitals open. But the other piece is simply, if the hospital closes, not only is it the patient in danger of not surviving an hour-long drive in a hospital in an ambulance to the nearest hospital, because that's the critical access hospital mantra. It's like, keep them open so they don't die in an ambulance ride, right? But it's more than that, because the patients simply don't want to go to the big urban hospitals. They're scared of them. They're not comfortable going there. They're more comfortable going to their community hospital where the doctor that they've always known growing up, works. And that's where they want and expect their health care to be delivered. And so the real key is this technology that's constantly being developed and improved, is to get that technology out into the rural hospitals so that you don't have to send the patient into the urban hospital where the technology is.
Makes sense. Well, some big problems at hand, but we appreciate the discussion, learning more about the field in general and your guys' time here on the podcast. So we'll wrap up, but thanks so much for joining us today.
You're welcome.